Hi, good night, everyone. My name is Vikash Rampasad, and tonight I'll be presenting mesenchymal non-meningothelial tumors of the CNS. So, by definition, mesenchymal non-meningothelial tumors of the CNS are a group of benign and malignant entities that may affect the CNS as primary, secondary, or metastatic entities. These correspond to soft tissue tumors as encountered in other organs. Soft tissue tumors are a heterogeneous group of tumors classified along a different line of differentiation according to the adult tissue that they resemble. Mesenchymal tumors relating to the brain and spine tend to arise in meninges rather than the parenchyma. Primary mesenchymal CNS tumors are very rare. So firstly, we'll be talking about the solitary fibrous tumors. Historically, these have been known as hemangiopericytoma. So the solitary fibrous tumor is a mesenchymal tumor of fibroblastic type showing a rich branching vascular pattern with a histopathological spectrum, including tumors previously classified separately as meningeal solitary fibrous tumors and hemangiopericytoma. However, the revised fourth edition of the WHO classification of tumors of the CNS merged the two previously distinct diagnostic entities into a single category designated solitary fibrous tumor to align with the nomenclature that is used outside the CNS in tissues such as soft tissue, pleura, and other visceral sites. The epidemiology, so less than 5% of extraaxial CNS tumors are solitary fibrous tumors. Meningiomas are the most common. Typically, solitary fibrous tumors occur in middle-aged men, in middle-aged individuals, typically around the fourth to sixth decade of life, and there is no gender disposition. Clinically, they present as non-specific and identical to other dural masses. The symptoms depend on the size of the mass and its location, and it's typically related to mass effect. Headache is the most common presenting complaint. The location, the dura, and is most frequently found in the tentorium. Other sites include the falx. Other dural sites include the skull base, cerebellum, and pineal gland. So the radiological description on CT, solitary fibrous tumors appear as well circumscribed and isodense to hyperdense compared to adjacent brain. They may demonstrate calcifications and may erode bone if abutting it. On MRI, solitary fibrous tumors are similar to meningiomas, appearing as extraaxial, well-circumscribed masses. On T1, there's intermediate signal similar to the brain. On T2, there's iso to hypointensity, and this is the best clue to the diagnosis. There's a heterogeneous signal, which looks like a yin-yang appearance of separate areas with low signal and high signal intensity that may be characteristic. Flow voids are also commonly seen. These regions of high and low signal are consistent with its fibrous collagenous composition. T1 with contrast shows vivid diffuse heterogeneous contrast enhancement of low T2 signal components. A dural tail may be present, but it's much less common than in meningiomas. The diffuse weighted imaging regions of restricted diffusion are also frequently seen, and on MRS, lipid and lactate elevation or myoinositol elevation. So here we have a T1 and T2 weighted brain MRI scans showing a voluminous extraaxial mass in the right tentorial and supratentorial spaces. And this is a solitary fibrous tumor of a 41-year-old male with a 2-week history of focal seizures. It's a well-defined solid lesion on the right temporal region demonstrating a hyperdensity on contrast, as seen in A, with enhancement following contrast administration. MRI performed for further evaluation shows homogeneous hypointensity on T1 weighted images and moderate enhancement on post-scan images. No significant dural tail was noted. The most striking imaging feature is the marked hypointensity on the T2 weighted and FLAIR images. So the grading of solitary fibrous tumors. Solitary fibrous tumors of the dura can be graded from WHO grade 1 to WHO grade 3. And well, they were previously known as hemangioparasite tumors, representing WHO grade 2 or 3 tumors. So WHO grade 1, they are hypocellular collagenized tumors characterized by low cellularity, abundant collagen, and mitotic activity less than 5 per 10 high power fields. WHO grade 2 are more dense, higher cellularity, less collagenous with a mitotic count of less than 5 mitoses per 10 high power fields. And the WHO grade 3 is similar to grade 2, but with more than 5 or more mitoses per high power field with the presence of necrosis. The macroscopic appearance of solitary fibrous tumors, they appear well circumscribed and firm, and microscopically they demonstrate thick bands of collagen separating areas of hypercellularity and hypocellularity. Staghorn vessels are commonly seen in solitary fibrous tumors. The immunophenotype of solitary fibrous tumors, they are typically CD34 positive, Vimentin positive, but the demonstration of the STAT6 nuclear expression is highly recommended to confirm the diagnosis of solitary fibrous tumors. And this actually is a result of the genomic inversion at the 12q13 locus. And it's usually EMA negative. So the treatment of solitary fibrous tumors, all solitary fibrous tumors are treated with total resection. In grades 2 and grade 3, treatment is often supplemented with adjuvant external beam radiation therapy. Patients may be monitored for many years and even decades to evaluate for recurrence and metastases. The prognosis, surgical resection, if complete, is usually curative. However, if incomplete, or recurrence occurs, then radiotherapy may be employed. So next we will look at hemangioblastomas. These are benign, slow-growing, highly vascular neoplasms containing neoplastic stromal cells, which usually involve the cerebellum, brainstem, or the spinal cord. Generally, these are associated with the loss of inactivation of the VHL gene, with frequent occurrence in von Hippel-Lindau syndrome. They are WHO grade 1 tumors and can occur in the CNS or elsewhere in the body, including the kidneys, liver, and pancreas. They account for approximately 1 to 2.5% of all intracranial tumors and approximately 10% of all posterior fossa tumors. The epidemiology of hemangioblastomas, they occur 0.141 per 100,000 person years, and they are slightly more common in males, with a female ratio of approximately 1.25 to 1. Its peak incidence is around the third to sixth decade of life. However, in patients with von Hippel-Lindau syndrome, it may be earlier in the second to third decade of life. Sporadic cases, which are cases not associated with von Hippel-Lindau, make up approximately 75 to 80% of hemangioblastomas, with the remainder being found in patients with von Hippel-Lindau. That would be around 20 to 25%. Sites of occurrence, so common sites include the cerebellum, the brainstem, and the spinal cord, whereas uncommon sites include the cerebrum, optic nerves, and peripheral nervous system. Hemangioblastomas clinically present with headaches, hydrocephalus, and increased ICP, cerebellar dysfunction in the form of dysmetria or ataxia, altered mental state, secondary polycythemia due to erythropoietin production in roughly 20% of cases, retinal hemorrhage, retinal detachment in cases of retinal hemangioblastomas, and brainstem hemangioblastomas are associated with hypostasis, dysphagia, hyperreflexia, headache, and reduced appetite. So, von Hippel-Lindau syndrome. This is a familial neoplasia syndrome with autosomal dominant transmission. It's caused by a gene mutation in the VHL gene, the tumor suppressor gene on chromosome 3p 2526 that codes for VHL protein, which is a part of the protein complex VCB-CUL2. Biallelic inactivation, a two-hit model, is required for tumor development. Approximately 80% of cases are inherited from the autosomal dominant gene mutation in the affected parent, whereas approximately 20% of cases result from spontaneous mutation that occurs in the sperm or egg. The primary cause of VHL disease-related morbidity is renal cell carcinoma and CNS hemangioblastoma. So these are just some of the manifestations of von Hippel-Lindau disease. You would see that cerebellar hemangioblastoma, retinal angioma, and renal cell carcinoma are by far the most common, whereas spinal hemangioblastoma, adrenal or extra-adrenal pheochromocytoma, endolymphatic sac tumors, multiple renal or pancreatic cysts, and pancreatic neuroendocrine tumors are less common. So the classification of von Hippel-Lindau syndrome could be type 1 or type 2. Type 1 is the absence of pheochromocytomas, whereas type 2 is the presence of pheochromocytomas. Type 2 could be further classified into A, B, and C, with 2A involving renal cancer, 2B without renal cancer, and type 2C only involving pheochromocytomas. So the diagnostic criteria for VHL, the diagnosis can be made whether or not there's a positive family history. In the event of a positive family history of VHL, at least one of the following can indicate a diagnosis of VHL, and that's the retinal, brain, or spinal hemangioblastoma, a pheochromocytoma, renal cell carcinoma, or pancreatic endocrine tumor. And in the case where there's a negative family history of VHL, the presence of two or more of the following can indicate a diagnosis of VHL, and those are hemangioblastomas, multiple renal or pancreatic cysts, renal cell carcinoma, adrenal tumors, endolymphatic sac tumors, or pancreatic neuroendocrine tumors. So surveillance and additional tests. Surveillance for VHL is very important. Individuals at risk, including those with a family history or suspected VHL, need regular surveillance. And this may include annual ophthalmology exams, MRI scans of the brain and spine, as well as blood tests. Screening may be discontinued at 60 years of age if nil abnormalities are detected. Molecular genetic testing is also important. Genetic testing can help confirm or rule out von Hippel-Lindau syndrome in cases where clinical criteria are not met. Different diagnoses for VHL. It's important to differentiate VHL from other conditions that can cause similar symptoms, such as multiple endocrine neoplasia, neurofibromatosis type 1, and other hereditary syndromes. So the features of hemangioblastomas. Hemangioblastomas are red, orange, or bright red and are invariably associated with high vascularity. They are well circumscribed, encapsulated tumors that may feature intratumoral cysts, but are more frequently associated with peritumoral cysts whose walls are composed of compressed brain tissue and reactive gliosis. Histologically, these tumors are characterized by the proliferation of stromal cells and endothelial cells, and are similar to renal cell carcinoma metastases. Thus, immunohistochemical differentiation is important. So the radiographic features, hemangioblastomas most commonly consist of a large cyst with vividly enhancing mural nodule, which often has a prominent serpentine flow void. Less commonly, the tumor is associated with no associated cysts. The solid component may have smaller cystic spaces within it and often abuts the pia mater. Approximately 80% of hemangioblastomas involve the peritumoral cyst formation. These are formed when there is increased vascular permeability of the hemangioblastoma, resulting in extravasation of the plasma infiltrate into the tumor interstitial spaces. High interstitial tumor pressure drives the fluid into the surrounding parenchyma, and peritumoral edema is formed when the resorptive capacity of the peritumoral tissue is exceeded. The mismatch of fluid production and tissue resorption favors the formation of a cyst as surrounding tissue stretches and swells. Most of the excess interstitial fluid then flows along the path of least resistance into the peritumoral cyst, thus expanding it. On CT, the mural nodule is isodense to the brain on non-contrast scans, with fluid density surrounding the cyst. Post-contrast, there is intense homogeneous enhancement of the mural nodule. The cyst walls do not usually enhance. On MRI, the mural nodule is hypointense to isointense on T1 weighted imaging and vividly enhances with contrast. On T2, the mural nodule is hyperintense and fluvoids due to enlarged vessels may be evident, especially at the periphery of the cyst, which is seen in 60–70% of cases. T1 weighted MRI after application of contrast media. So we have the axial section revealing a peritumoral cyst adjacent to solid cerebellar hemangioblastoma. Note that the cyst wall does not enhance with the contrast media. And in B, the coronal section of another cerebellar hemangioblastoma with a large intratumoral cyst. So note the difference between the peritumoral and the intratumoral cysts. And this is a T1 weighted contrast enhanced axial image of a cerebellar hemangioblastoma, solidly enhancing area with associated cysts as well. Angiography reveals enlarged feeding arteries and often dilated draining veins demonstrated and a dense tumor blush centrally. Management and treatment of sporadic hemangioblastomas. So these are the hemangioblastomas that are not associated with von Hippel syndrome. Microsurgical resection is usually curative, and most craniospinal hemangioblastomas that are not associated with VHL can safely be resected. Preoperative embolization may help reduce the vascularity of the hemangioblastoma. When the tumor is associated with a cyst, the gliotic cyst walls are left undisturbed because they are not neoplastic, and simply removing the tumor leads to inactivation of the cyst, which subsequently collapses. 5-ALA fluorescence may aid in the visual localization of the small hemangioblastomas within the cyst wall. When complete resection of the tumor is achieved, recurrence is rare, and stabilization or improvement of symptoms occur in approximately 90% of patients. Management of VHL-associated hemangioblastomas is a little different. Surgical resection of the individual CNS tumors is usually reserved until patient is symptomatic in order to decrease the number of operations over a lifetime. Since the tumors in VHL are usually multiple, they tend to reoccur, and the growth pattern is saltatory. Surgery, however, is the treatment of choice for accessible cystic hemangioblastomas. Stereotactic radiosurgery may provide local control rates of more than 50% over 5 years, and it has been recommended for asymptomatic hemangioblastomas more than 5 millimeters in diameter if they are cystic or progressing in size during surveillance. And surveillance, like we said, is very important for VHL. Usually, this would start with clinical examinations between the years 1 to 4, and at 5 to 15 years, the clinical examination, biochemical tests, abdominal ultrasound, abdominal MRI, and MRI of the brain and internal auditory canal may be done. And during adulthood, at more than 16 years, all of these are done as well, including the MRI whole spine. And this lasts up till 60 years, where they can be discontinued if all the scans are negative. So the prognosis of VHL. The lifespan of patients with VHL is decreased. The primary causes of morbidity and mortality are renal cell carcinoma, metastases from renal cell carcinoma, and neurological complications from cerebellar hemangioblastoma. Typically, these metastases respond poorly to chemotherapy and radiotherapy. And next, we'll talk about melanocytic tumors. These tumors may be diffuse or localized CNS tumors that presumably originate from the leptomeningeal melanocytes. Diffuse melanocytic tumors are rare and strongly linked with neurocutaneous melanosis. These include melanocytosis, which is diffuse benign lesions without macroscopic masses and no brain invasion, and melanomatosis, which is malignant diffuse or multifocal lesions and often invades the brain. The solid melanocytic tumors, on the other hand, include melanocytomas, which are benign or intermediate grade tumors, and melanomas, which are discrete malignant tumors. So melanocytosis is a benign form of primary melanocytic tumor of the CNS that represents proliferation of melanocytic cells within the subarachnoid space. When associated with cutaneous melanocytic lesions, the condition is known as neurocutaneous melanosis and is a rare congenital syndrome with giant congenital pigmented skin nevi. It usually presents before the age of 2, and diffuse melanocytosis can involve infra or supratentorial leptomeninges, but has the highest frequency in the cerebellum, brainstem, and temporal lobes. These tend to have a poor prognosis even when histologically benign. Clinical features of melanocytosis, these include features of neurocutaneous melanosis. So they have the congenital nevi. This can also be manifested as a bathing trunk when located on the patient's back. Hydrocephalus, which is the most common complication, mass effect, and neuropsychiatric symptoms, typically when presenting in the second decade of life. Neurocutaneous melanosis, which consists in a rare non-hereditary phakomatosis, is characterized by large or numerous congenital nevi in a patient with meningeal melanosis or meningeal melanoma, and most commonly presents in childhood during the first year of life. Melanomatosis. Meningeal melanomatosis is an aggressive version of meningeal melanocytosis and one of the recognized primary melanocytic tumors of the CNS. There's a strong association with neurocutaneous melanosis as well. Primary CNS melanoma arises from the leptomeninges and spreads diffusely around the subarachnoid space and virtual Robin space, often with invasion of the CNS. So this is a case report taken from the World Journal of Clinical Cases, and it is a case report of a 44-year-old woman with a 1-month history of headaches with no relief. She had no nausea, vomiting, or seizures noted. The patient was born with a diffuse melanosis of the skin, mainly covering the back of the trunk, shoulders, and neck, with multiple satellite nevi on the limbs, and a few hairs on the surface of the nevi in the first few years after birth. There was no past history of skin or CNS disease or malignant tumors. The patient had no history of surgery, and her parents and children had no history of congenital nevi or melanoma. MRI examination of the head revealed a mass with intramural cysts located on the left temporal lobe. The solid part of the tumor was hyperintense on T1 weighted images and hypointense on T2 weighted images, and the cystic components showed the opposite. The pathological results showed malignant melanoma, and the patient was ultimately diagnosed with neurocutaneous melanosis with malignant melanoma. The patient underwent surgery to remove the intracranial mass after admission. During the operation, the tumor appeared blackish brown. The peripheral leptomeninges were also stained black with light yellow sac fluid inside, and the blood supply to the tumor was extremely rich. First, the cystic fluid was drawn out, and the lesion was then gradually separated along its periphery until it was completely removed. The pathological results showed malignant melanoma. The patient was in good condition after the operation. She refused further radiotherapy and chemotherapy and was discharged on the 10th day after the operation. However, 5 months after the operation, the patient went to a local hospital due to unconsciousness after a severe headache and died of ineffective treatment. The death was considered to be due to obstructive hydrocephalus due to tumor progression. melanocytoma and melanoma. These can occur anywhere along the neuroaxis and thus may be intracranial or spinal. They are most commonly found in the spinal canal near the foramen magnum, the posterior fossa, Meckel cave, or adjacent to the cranial nuclei. Intraventricular location of such tumors is extremely rare, with only a few cases reported before. Patients in all age groups. This is present in all age groups, but peak at the 5th decade of life. Melanocytomas are more common in women. These both clinically present mass lesions depending on their location and may associate focal neurological signs. There may be spinal cord compression, intracranial hypertension, hemorrhage, and seizures. Meningeal melanoma is associated with neurocutaneous melanosis as well. So radiological features. Extraaxial masses with homogeneous enhancement on post-contrast images on both CT and MRI. There's hyperintensity on T1 weighted images and hypointensity on T2 weighted images. There's abnormal calcifications that may be present as well. Most common location for meningeal melanocytomas is the intradural extramedullary compartment, whereas the intramedullary location is rare. Meningeal melanomas can be intradural or extradural. Invasion of the CNS parenchyma is associated with malignancy. Melanocytomas present as tight nests of slightly spindled, well-differentiated melanocytes containing various amounts of melanin. Melanomas consist of spindled or epithelioid cells arranged loosely in nets, fascicles, or sheets with variable cytoplasmic melanin pigment. The distinction between melanocytoma and melanoma rests on the identification of cytologic atypia, mitotic activity, necrosis, and neural parenchymal invasion. So the treatment and prognosis, melanocytomas, although classified as benign, meningeal melanocytomas may behave aggressively and a limited number may actually transform to malignant melanomas. Complete excision is the treatment of choice in melanocytomas. However, it is not often possible as intraoperative hemorrhage may be severe. Furthermore, local recurrence has been reported even after gross total removal. Due to a risk of recurrence even after complete excision, adjuvant radiation therapy is advised in cases of both complete and incomplete resection. Melanomas are aggressive lesions with a generally poor prognosis. Although they are localized, they have better prognosis than melanoma metastases to the dura. All right, and that brings me to the end of my presentation. These are my references. I thank you, everyone. Any questions?